Hello, everybody. Today we are talking about Ehlers-Danlos Syndrome, and I'm Naila Goldenberg from Functional Endocrinology. I want to start that I became interested in Ehlers-Danlos because I found that a lot of my more complex patients have this hypermobility syndrome, and because of that, I was trying to read about it and read about conditions that come together with that. And because of that, that was my personal interest. So today I want to share with you what is EDS, Ehlers-Danlos Syndrome, or what is joint hypermobility syndrome, and what other associated conditions, what is association with endocrinology, me being endocrinologist, why these patients even come to me, and what is the support for EDS, what can we do to improve the quality of life and stuff. So first, we want to go back to collagen. Collagen is our main protein in the body, and it's matrix of our body. It's a matrix of our bones, our tendons, our ligaments, and skin. And because of that, it's super important part of our structure. It's apparently about 30% of whole body protein content. The main amino acids that create the collagens are going to be glycine and proline, and they become a helix. You can see here their amino acids, they get together, then they bind to each other, and they create tropocollagen. Then tropocollagen will create fibrils, and then fibrils get into fibers and fascicles. So large and large. It's almost like imagining yourself when you have a thread of the, some kind of thread, you put it together, then you put it together again into larger bundles, and at the end you end up with the yarn. So that's a similar idea. And if one single thread in that yarn is very weak, but when you put it together, it becomes quite sturdy. So that same idea is here with the collagen. There are a lot of different collagen types, and apparently type 1 is about 90% of that collagen. So now, what is Ehlers-Danlos syndrome? Edward Ehlers and Henry Alexander Danlos, they described this term at the turn of 20th century. So it's relatively recently described syndrome, even though it was recognized by Hippocrates and even before. So it's apparently a combination, or it's a group of different inherited conditions, and now we found genetics behind of those conditions that affect our collagen. And because of that, it creates skin stretchability, joint hypermobility, and instability. There are different versions of Ehlers-Danlos syndrome. The classical version is about 5 per 100,000. Vascular version is much less common. It's 2 or 3 per million. And hypermobile version of EDS is about 10 per 100,000, or maybe even more. So the hypermobility spectrum disorder is technically diagnosis. It's more wider term, because not everybody can fulfill all the criteria for different specific versions of EDS. So EDS is part of hypermobility spectrum disorder, but there could be other versions of hypermobility that create hypermobility. And I would share with you that I personally have a version of hypermobility, but I don't fulfill criteria of EDS. And when we'll talk about criteria, I will share with you more. So this is very busy slide, but it technically describes 13 different types of EDS and what genetics bases are behind of each of them. The most common ones are hypermobile, and it's characterized by joints. People could be double jointed, but in addition to that, there could be soft, stretchy skin. mitral valve prolapse, and stuff like that. The classical type will have some degree of joint hypermobility, but less severe, but skin involvement becomes more pronounced. And skin becomes more fragile, soft, velvety, stretchy, and the wound healing becomes a little bit more delayed, and people get atrophic scarring instead of regular scars. And I'll show you pictures. The vascular version is kind of more worrisome. It's probably more worrisome. Why? Because people have trouble with vasculature and create aortic aneurysm that can lead to dissection and rupture. And because of that, actually, that could be, people can die from that. Then people may have bowel rupture and rupture of gravid uterus. So of course, this version is much more serious, but there are a few other types of EDS we are not going to focus on because they're not as common. So here we have pictures of what happens to skin in hypermobile versus classic EDS. And you can see that the scars look much thinner than compared to people who don't have any versions of Ehlers-Danlos syndrome. They're more like paper thin, and they look atrophic. Plus, people may have certain version of cysts, and because of that, they look abnormal. But it's not those molluscoid pseudotumors on the elbow. You can see it at G. It's not keloid scar. It's very different. But it's important to recognize that some people have that. And whole talk today is more about awareness, to bring your awareness, because most likely you know somebody who has EDS and they may not realize that. And we want to bring that awareness. So here's the signs of EDS, or major criteria for classical EDS. We have major criteria, minor criteria, and the combination of certain ones will put you into diagnosis. So the hyperflexibility, as I said, is very common, and we judge that by this Beighton score. You can see number one, it's if you can put your finger at more than 90 degrees if your hand is lays flat. So if you want to try and see if you personally can do it right now, and we judge both right and left hand, and if either one of them will be positive, then it's 1 point, or if it's 2, then it's 2 points. Then we look at number 2 criteria, when you can put your big finger, thumb, you can put it by your forearm. I personally never could do that, but I could do 1 and 5. Those 2 I definitely was able to do, and still able to do. I was able to do it as a child, and I still can do that. Again, we look at possibility of right and left, so you could be 2 points. Number 3 is double jointed elbows. And number 4 is double jointed or hyperextended knees. And number 5, of course, because there is no right and left, if you can reach your with your palms down to the ground, or even lower while you're standing with straight knees. So you can see the maximum criteria here will be 9 points. And depending on how many points you have, you could have one or the other. You could qualify for diagnosis of EDS or not. With classical EDS, you can see there is lots of minor criteria like easy bruising, soft, doughy skin, skin fragility, those molluscous pseudotumors, subcutaneous spheroids, nodules, hernias, especially hernias if it's a man who develops hernia. or if it's a woman who never was pregnant, has hernia or other things. So then there is epicanthal fold, that's your eyelids become more like mongoloid type picture. And then we have complications of joint hypermobility like sprains, subluxation of joints, and pain related to all of that, flexible flat foot. And always we want to see if there is any first degree relatives who meet the criteria as well. The hypermobility, we have a lot more requirements for the Baton score. You can see that in prepubertal kids, the score for hypermobility should be more than 6. For age more than 50, it will be more than 5, and older than 50, or up to age 50, more than 5, and after 50, it's 4 and more. And if you have score 1 point below cutoff, then at least 2 positive small criteria that can still qualify you for the hypermobility EDS. Then those are additional criteria that are required, and we're not going to go into depth. But I wanted to show you this physiogenic papule on the feet. Those are white spots that, because it's protrusion herniation through fascia of cutaneous fat, and you can see they're blanching white nodules only while bearing weight. If you lift your foot up, you will not see them. So that's another criteria, minor criteria for the EDS. So the vascular one, there are different criteria there, including the rupture of arterial rupture of aneurysm and spontaneous sigmoid colon perforation, uterine rupture, carotid cavernous sinus fistula formation in absence of trauma. And there are multiple minor criteria. Family history, again, is very important. And again, as I said, we worry about these patients more. And I had a patient who has clearly hypermobile EDS, and she had a lot of, and she still has a lot of bruising. And we always worried if she possibly has vascular EDS. But then we discovered that she has low vitamin C, and vitamin C is cofactor for creation of collagen. And when we improved her vitamin C level, her bruising and many other symptoms actually have improved. And that will be when we'll talk about our support for EDS. So comorbidities. There are different studies that I looked up into, and here's one of them is 1,319 Danish patients specifically with EDS, and they were compared to a cohort of 46,000, almost 47,000 patients, and they were found to have much more gastrointestinal problems, hernias, asthma, pneumonia, and osteoporosis. In another study, there was a strong association of hypermobility spectrum disorder and hypermobile EDS with ADHD and anxiety disorder too. And therefore, the suggestion was to screen kids with this condition for neuropsychiatric symptoms. The gut symptoms can be prevalent and could be all kind of. It can be bloating and distension after meals, dysphagia, dyspepsia, meaning people can have nausea after meal, people have problems swallowing, people can have a reflux, heartburn, diarrhea or constipation, and more frequently, EDS patients have more constipation rather than diarrhea, but diarrhea, of course, can happen too. And there could be, of course, different obstructive problems. The pain can be very prevalent. And part of that could be just instability of joints. Another part of that could be because people can have dislocations of joints. This particular study looked at patients and jaw movement, and a lot of people apparently had TMJ involvement and chronic pain because of that. And with that, 22.8% had depression, or more than half people had anxiety, and a lot of people perceived high stress. There is interesting association between EDS with postural tachycardia syndrome, and postural tachycardia syndrome is when people develop high heart rate when they stand up or stand for a long time. And it's technically dysregulation of autonomic function. Our autonomic nervous system doesn't work well, and people feel dizzy and ready to pass out if they stand for too long of a time. And in fact, the tilt test, table test, is one of these classical testing for POTS, is when you stand as long as it needs to be until you pass out. And occasionally people will get help with that. They will get like nitrates to help them reach that outcome in a sense. And if you passed out, then you actually have that dysregulation. The study confirmed that there was high rate and heterogeneity of abnormal autonomic dysfunctions in EDS patients, and that is what started me being interested in that, because POTS is condition that you want to diagnose with adrenal insufficiency. And I probably that was my entrance into EDS world, because I had patients who came to me with workup of fatigue and dizziness, palpitations, and I would worry about, of course, thyroid, but of course of adrenal as well. And then I would start working them up, but eventually we'll find that they're actually hypermobile, and we'll do the tilt test, table test, and they will end up having postural tachycardia. And I had several, and time after time that becomes, you start recognizing the pattern, and you can start asking patients about hypermobility much earlier in the course of diagnosis compared to what I was back 15 plus years ago. So interesting association of hypermobility and COVID. This group of physicians, they describe possibly new syndrome where young age female gender with joint hypermobility after COVID develop much more severe pain, and plus they get trauma or rupture of tendons, and they develop fibromyalgia pain syndrome over the next 6 weeks. We definitely know that COVID can trigger a lot of autoimmunities, and here people found in those patients, this group found a positive anti-nuclear antibody and markers of systemic inflammation. So that was interesting to find that, because I definitely have seen people with COVID who developed POTS, and I'm curious if people who develop POTS are mostly hypermobile or not. But of course, I don't have the answer for that, but it could be an interesting research project for somebody. There is interesting genetics with EDS, and this is one particular gene. There are, of course, different genes that are involved in EDS, and because of that, the association between EDS and other conditions could differ. This particular one is associated for 21 hydroxylase deficiency congenital adrenal hyperplasia. It's a special version of adrenal insufficiency, and the genes located relatively close to gene that transcribes this encodes serine protein kinase, which is involved into formation of collagen as well. And this particular gene associated with particular version of EDS. And of course, if you have genetic mutation in one area of the chromosome, you can shift everything else, and because of that, you can end up not only with one genetic abnormality but with several. And this is particular version is association of congenital adrenal hyperplasia, EDS, but we have other association. That's why there's possibility that EDS associate with POTS. And another interesting condition that's called MCAS. And MCAS is mast cell activation. We talked about mast cell activation weeks and weeks ago. I don't know if you remember that or not, but there are special cells called mast cells, and they are part of white blood cells, and they go into tissues and they become mast cells that carry different chemicals, histamine, tryptase, and many other ones. And when they release those chemicals, then people start developing symptoms of flushing, itching, hives, angioedema, nasal congestion, wheezing, possibly diarrhea, cramping, and so on. So again, symptoms of MCAS, NPADS, and EDS frequently coexist and frequently interlap. And up to 25% of patients with hypermobile EDS also have MCAS, which is much higher compared to other population. And 9%. And here in this survey of people with POTS, 25% of them have EDS, 9% of them have MCAS, which is again shows the connections. And other questionnaires, 66% of patients diagnosed with both POTS and EDS reported symptoms suggestive of MCAS. MCAS, unfortunately, is not easy to diagnose. It's a kind of you have to do special testing for tryptase before the episode and then right after episode, but it's hard to catch it exactly on time. But still, there is enough of, if you have enough of clinical symptoms, you can try treatment with antihistamines and other therapies that exist right now for MCAS. So this is what we do to support our EDS. This actually wonderful article that was published relatively recently. I don't remember if it's 2020 or 21, but it was the main premise that people with EDS frequently have a problem with absorption and nutrition abnormalities, and many symptoms can be related to those nutritional abnormalities. And because of that, we want to find them and treat them. And therefore, symptoms, like here it says, we hypothesize that symptoms associated with EDS may be successfully alleviated using a specific and potentially synergistic combination of nutritional supplements. And they propose calcium, carnitine, coenzyme Q10, glucosamine, magnesium, MSM, which is methylsulfonyl methane, pycnogenol, silica, vitamin C, vitamin K at doses that have been previously demonstrated to be effective against those parts. So this article was written by 4 people, and 3 of them work for different universities, which tells me they work in academia. And I was very pleased to see that this article was very thorough and went into gut health, description of small intestinal bacterial overgrowth and how to deal with that, description of supplements for fatigue, for actual joint support, and the summary is partial summaries here, but of course I just couldn't put that particular chart, it was too big. So there's suggestions for supplements: vitamin D 5,000 units per day, vitamin C between 750 and 1,000. Usually daily dose of vitamin C is about 100 milligram, But for patients with EDS, I definitely agree with 750 to 1,000, and some people may need even higher amounts because vitamin C is cofactor for creation of collagen, and because of that, the supplementation with higher amount of vitamin C is super important. MSM, methylsulfonyl methane, is very good supplement for joint pain. Silica has multiple function in a sense. It's great for bones, great for skin, and because of that is a good supplement for EDS. Vitamin B12, of course, is a super important vitamin, especially if it's methylated, because I bet many people with EDS have MTHFR gene mutation. We talked about that multiple times, that we require methylated versions of B12 or folate if we have that particular gene mutation. And it's great not only for nervous system or creation of red blood cells, but it's a great part of detoxification. Vitamin B1, I'm learning a lot more about B1 vitamin. There is a fat-soluble version of that, and water-soluble, and the fat-soluble version goes into your brain and helps you helps to support neurological system and helps to support brain function. Plus, it's shown in several studies to help with potentially with Parkinson's and many other things. There is full B1 deficiency related hyperglycemia. It can be associated with oxalates and so on. So B1 appears to be a great vitamin to supplement. So I definitely urge patients to try that. Unfortunately, there is no good B1 test because actual B1 is not representative of what's happening in the tissue. So you may just want to try that fat-soluble vitamin B1 and see how that works. They do suggest the antioxidants, and for the guts support, you of course try the diet, gluten-free diet, FODMAP diet, probiotics, including naturally occurring probiotics like kimchi or sauerkraut, and so on, and prebiotics that will help to support your gastrointestinal tract. For fatigue, they suggest that NAD supplement, coenzyme Q10, alpha-lipoic acid, and so on. So those are all nutritional things that you can do for EDS patients. I haven't seen their zinc. I do believe zinc is an important part because it is cofactor as well to formation of collagen, and iron. You want to optimize your iron levels. And between all of that, nutritional support, you hopefully supporting the production of collagen, and if it requires quick regeneration, you will have the machinery to do that. And pain management becomes another part of the EDS patients, and there are special versions of physical therapies that are created specifically for patients with EDS. Therefore, if you have patients with EDS, you want to have them see therapists that is familiar with that condition and builds you up from below to top, rather than from top to feet. So there are different versions of the physical therapy specific for that. And I wanted just to finish up that May is EDS and Hypermobility Spectrum Disorder Awareness Month. And just, of course, right now is November, but 6 months from now we'll have May, and it's good to be aware of that and be aware of EDS and hypermobility in general. As conclusion, the EDS and hypermobility is a complex condition. It's frequently underdiagnosed. There are complex treatments because one part is when you're treating actually EDS, the hypermobility or skin issues, but not other parts is when you are involved in treatment of PATS, if you're involved in treatment of MCAS, mast cell activation, or other things, that becomes definitely much more complex. From endocrine perspective, I did not find anything related to actually adrenals besides that particular combination of CH and EDS, or hypothyroidism. But clinically, as I said, majority of my patients who are more complex and have MCAS and PATS and EDS, they usually have hypothyroidism, and few of them will have adrenal insufficiency. Many of them have malabsorption, and because of that, they end up on pump for hydrocortisone delivery because their ability to absorb hydrocortisone is not sufficient to keep them out of adrenal crisis. This is all for right now. Let me finish the recording and we'll talk about the questions.